I'm Rick Berry.
Rick, hi.
Meeting with you
Oh,
later.
yeah, this afternoon,
I
right.
saw you asked the question.
Okay, we're going to go ahead and
Yeah.
get started.
The AAMC meeting?
EPIS conference.
Welcome,
The
everybody,
report out on that, yeah.
to the Timothy A. Johnson Medical Scholar Seminar Series. As most of you in this room know, this is a seminar series that is devoted to bringing in medical scholars, and by definition, that means somebody who is combining the care of patients with research, whether that be research in a clinical area or research in medical education or a number of different arenas. And the idea is we're going to provide you examples of what we think eventually both our medical and our graduate students can go out and do, which is do research together and broaden our knowledge base. So I'm going to not introduce our speaker. I'm going to hand over that honor to Dr. Andrew Binks.
So, don't clap me, it's him. Normally these introductions are a potted look at somebody's CV, and Richard's was too heavy to carry over, so I'm going to tell you a brief story. The first time I met Richard, I was a very nervous postdoc, sat in a lab at the Beth and Deaconess, and I'd just been told to mechanically ventilate my PI and then bronchoconstrict him while he was on the mechanical ventilator. This was my first mechanical ventilator and my first PI. There was a chance that one of them wouldn't make it through the morning. Richard then walked through the door, and this was a very, very busy clinician, and I was with rounding with him and going to his clinics. I found out this was a clinician who in a very compassionate way used the scientific method to help his patients. And he helped the most difficult patients that there were. He saw my anxiety and sweat behind this ventilator, and he gave me a 30-second primer on how to mechanically ventilate somebody. This man was also an educator, and he gave me the information that I needed it, when I needed it, and told me it thoroughly. He then stood behind me and said, "You got this, I'm right behind you." He was a mentor and a coach as well. I was later to also find out, with all the subsequent lab meetings that we had together and all the subsequent studies, that he is an incredibly thoughtful man, knowing the power of a good question and the methodology to answer that question. So to prove what I've just said, I'll introduce Dr. Schwartzstein as the Ellen and Melvin Gordon Professor of Medicine and Medical Education at Harvard Medical School. He gained his medical degree at Harvard Medical School, and he is currently the Division Chief for Pulmonary and Critical Care at the Beth Israel and Deaconess Medical Center. He's Vice President for Education at Beth Israel, and he was the Director of Harvard Medical School's Academy from 2009 to 2017. He's a Director of Educational Scholarship, and he has received numerous teaching awards. In terms of research, he has over 160 publications of books, chapters, papers, editorials, etc., etc. And this is the most genuine pleasure to actually introduce Dr. Schwartzstein to come and talk to you today. Thank you very much.
Well, thank you, Andrew, for really a very kind introduction. We were trying to get rid of his PI at the time, is what we were doing with the ventilator. This has really been a wonderful, it's not even 24 hours yet, visit down here, and you have spectacular faculty, a wonderful program and facility, and it's really been a real privilege for me to visit with you, and I think you've got great things ahead of you. I was asked to talk about research and a little bit reflecting on my own career, which I feel I've been very fortunate to have, in that I've been able to blend the different things I've been doing, the research, the clinical, the education, in a way that it all integrates and fits together for me. So every day is different from the day before because of the varying blends of those three things, and it's a really nice thing to be able to do. And the title of this is my medical research, as opposed to my education research, has been focused on shortness of breath. And it didn't start that way in my fellowship. I started out doing some physiology work. Some was on projects that my lab was involved with before I entered, some with some ideas that I had, but it was with asthma, it was with some other control of ventilation things. I worked on patients with spinal cord injury, looking at control of ventilation in those patients for a while. And then one day we were in a lab meeting with one of the best teachers I've ever known. It was an anesthesiologist and who worked with us for a number of years. And we were talking about pain and how people describe pain, and I said, gee, what do we know about shortness of breath and how people describe shortness of breath and what that means physiologically and stuff? And literally from that one question at one lab meeting, I then built the next 30 years worth of research basically came out of that, and derivative questions that came along the way. So, so it is all about asking questions. And I think, as I just said in the luncheon that we had, that for physicians in particular, that should be a mantra for you for your clinical work as well. It's about asking questions of your patients, not just about their medical condition, their symptoms and signs and things, but about who they are as people, which is going to give you tremendous insight into their illness and their life at home, and makes medicine a whole lot more fun and interesting as well if you take that approach. So this is going to be informal, and we have a whiteboard in case I need to draw something, which is common for me to feel like I need to do that, but interrupt at any point because we don't have to cover it all, as we were talking about last night, right? So in the beginning, so here were some of the initial questions that I had. We interview a patient who has pain and we say, what does it feel like? And we ask that because it helps us understand what's going on. Abdominal pain, if it's sharp, it means I'm stretching the capsule of an organ. If it's localized, it's probably peritoneal. If it's diffuse and kind of crampy, it's probably a visceral pain that relates to peristalsis and things like that. So it tells us information. And we recognize there are many things that cause pain, whether it's chest pain, abdominal pain, whatever. But we ask somebody who's short of breath, and they say, yeah, I'm short of breath. Rarely do people say, what does it feel like? And yet people get short of breath for a whole long list of reasons. Do we think that the pathophysiology of all those things is the same? No, clearly not. And yet we haven't done that. So we ask them things like how far can you walk and what makes it better, but we don't tend to ask what does it feel like. So what we're going to talk about today is a little bit of the development of what we call dyspnea questionnaires, which is getting at what these qualitative phrases are all about. Linking that to physiology, because ultimately that helps us understand what's happening from a disease standpoint. Talking a bit about what we now refer to as a multidimensional model of dyspnea, because dyspnea can be an incredibly powerful sensation, and it evokes a lot of behavioral responses and other emotional responses as well, which then kind of feed back into the sensation itself. And talk a little bit about some treatments directed at the physiology as well as the affective dimensions. But I started to make questions, and this is one of my favorite quotes from Einstein. And I always say I love Einstein quotes because usually people don't fuss with me about them. It's a tough person to challenge. But I'll let you quickly read it yourself. But think about the import of this statement, which you could argue is a little bit of hyperbole, but nonetheless, it's important that asking questions, figuring out which questions to ask to understand a problem, are more important than jumping to the problem itself or what the final solution is. And again, this is very important in medicine, I think, as well as in research issues. I often tell the students that when I teach about critical thinking, which is one of my big interests from an education standpoint, I go back to the movie Apollo 13, which unfortunately is like becoming an old movie, but have people seen Apollo 13? So it's about one of the moonshots, right, and there's an explosion on the capsule and carbon dioxide rising in the capsule, and they're not sure they're going to get the guys back. And there's a scene in Mission Control where there's like pandemonium. Everybody's running around like crazy. There's noise, panic going on, and Ed Harris, who plays the director of Mission Control, says, I want you all to settle down. I want quiet. I don't want guessing. Guessing makes things worse. I want you to work the problem. What did he mean? What do you think he meant at that moment? Now, he's looking at a room full of incredibly good engineers and other scientists that they employ and use, for these space shots. What did he mean by work the problem?
Ask the right questions.
Ask the right questions? What else might he have been talking about? So work the problem. When he said guessing, did he really think they were going to guess? I mean, these are incredibly intelligent, well-trained engineers. What was he talking about?
I imagine that he recognized that they had a limited amount of time and energy, and he wanted people, before they got down a rabbit hole, or to really be efficient with their time and resources in solving the problem.
So be efficient, but not looking for the solution right away. Worry about the pattern recognition, that going down the rabbit hole as you suggested, right? If I've jumped to a solution right away, I may get into trouble with that. And so I think what he was talking about is start by asking the right questions, by getting at intermediate issues. What do I know about CO2 accumulating in the capsule? What's going to determine the rate of that? How much time will I have? How do I get rid of CO2 in a generic sort of way? What do they then have available that's on the spaceship, right? And how do I work with that? So there's all these intermediate questions that I made, that's Einstein, right? I spend 55 minutes figuring out the questions I need to ask. First, that's how I work the problem. And when you see a patient who's hypoxemic or hypotensive or having the issue shouldn't be jumping to the diagnosis right away. It should be, what do I know about those things? How do they work? What are the intermediate steps that will then keep me thinking broadly about it, not go down a rabbit hole, if you will, of an erroneous first assumption. So a lot of this is avoiding pattern recognition as well. The first thing that pops into your head because you've seen this commonly before, perhaps, or something that looks like that. So I think that's what he meant there, and I think that builds off of this notion of asking questions. So I'm going to start with a little case, and I know first-year students, Dr. Binks told me, haven't gotten into this much yet in terms of physiology and things, and that's fine. But a patient with COPD comes in. He had lung cancer removed 6 months ago, and he's complaining of shortness of breath, and he describes it as a huffing and puffing sensation. I just seem to be breathing too much. I'm breathing more, and it doesn't feel right. And this is an interesting phenomenon about, again, what people assume is a sensation versus a symptom. When is it cross from one to the other? That's an interpretation the patient's making that this is a bad thing, but you might have huffing and puffing and not think about it, but this patient at least was distressing, and they thought something abnormal was going on. And you examine the patient, and he's a bit overweight, breathing at a pretty normal respiratory rate, a little bit tachycardic, and he's got a hyperinflated chest with diminished breath sound, which is very typical of emphysema, and a prolonged expiratory phase, again, increased resistance in the airways, airflow obstruction. Diminished heart sounds kind of goes with a big chest, a lot of air between the stethoscope and the heart, no gallop, which is an abnormal heart sound that would suggest maybe heart failure, and he has no edema, which might, if he had heart failure, might see edema, and a little bit of clubbing, which is a change in the fingernails we associate with lung cancer and some other conditions. So the question is, what's the cause of this shortness of breath now? What are the diagnostic tests and any therapy? Anybody have any thoughts? It's, again, beyond probably where you are as med students, but go ahead.
Well, you stated that recently you had a resection, potentially you've lost the surface area of the gas exchange, and it's got a large body, so we can't get the CO2 out before the oxygen.
Right, so maybe he's developing hypercapnia, acute hypercapnia, or he's hypoxemic, so is there a problem with gas exchange? Very reasonable consideration here. Any other thoughts anyone wants to bring up?
On a spirometer, see if it's oxygen getting in or oxygen respiration occurring at the lung.
All right, so it's spirometer, which will give us a measurement of how much he can breathe in and out and how fast he can get the air out. So maybe his obstructive lung disease is worse as well, or maybe he's just lost so much lung tissue, he's had a big drop in how much he can do. So those are very good things to think about as well. So breathing discomfort is the term that I use and that the ATS, the American Thoracic Society, now uses as sort of the generic thing. So, you know, there's an old story about pain, asking questions. You go in and you ask a patient, do you have chest pain? The patient says no. And you totally miss that they're having myocardial ischemia. Why is that? And let's not even worry about whether it's intermittent or not. Have you had chest pain in the last week, you know, and they say no. What's wrong with that question?
A lot of people don't have chest pain, especially like women might manifest differently. You don't always have chest pain.
Okay, so there's that part. Maybe it's arm discomfort or something else, and there are differences between men and women. Great.
Maybe the patient has a different definition of pain.
Different definition of pain. Because you know what? If I tell you I have pain, you're going to do something bad to me, right? You know, and so it's not really a pain, doc. I'd call it kind of a discomfort.
Right.
Now, they may not say that. They may just say no to the pain, right? So we've kind of adopted the same strategy, and the group at the American Thoracic Society to say, well, I don't ask people about short of breath. Tell me if you have any breathing discomfort. Is there anything uncomfortable about the way you breathe? No. Oh, I'll tell you about that. I wouldn't call it shortness of breath, but, you know, it's a little bit uncomfortable to breathe. So we use that term, and it's a subjective experience. Now, people say, you know, dyspnea ratings are baloney because it's all subjective. Is there any symptom that's not subjective? I mean, by definition, symptoms are subjective. If you ask for a pain rating, it's subjective. I mean, but that's what it is. Only the patient can tell you if they have a symptom. Can you look at a patient and tell they're short of breath? No. No, you can't. You can say they're in respiratory, they're demonstrating signs that we associate with a problem with the respiratory system. Whether or not they're short of breath, I don't know unless I ask them. I've never seen an unconscious patient who was short of breath. Now, not because they're not short of breath, and we were talking about this at lunch a little bit. The parts of their brain may be lighting up to tell us that they're short of breath, but they're not going to tell me about it, so by definition, I can't tell whether or not they're short of breath. And there have been studies that have asked nurses and doctors to assess how short of breath somebody is by looking at them, and then they ask the patient how short of breath they are, and they're not correlated. The healthcare professionals underestimate what the patients will tell you about the intensity of their shortness of breath. So it's good to remember that. Qualitatively distinct sensations, which we've been talking about, and the result of these interactions between physiology, social factors, and environmental factors. And they may lead to other psychological and behavioral responses and have associated symptoms. So the pain people were ahead of people in terms of shortness of breath with these kinds of questionnaires, and this was one of the early ones looking at headaches and saying that if I looked at these sensations that people describe, the descriptors, you could decide in a probabilistic way that somebody is more likely to have, say, a tension headache as compared to migraine headache. And that's, again, doctors have been doing this sort of thing for a long time, although this was a formalization of this almost 40 years ago now, but we weren't doing it at that early stage with shortness of breath. So when I had asked that question at this lab meeting, we started to say, well, there was this data, so this was like 1984 or 5, it was a few years after this data got published about the headaches, and so we started to develop our own list of phrases, and we went out initially, developed this by talking to patients and starting to ask them the question, what does it feel like? And so from that, we kind of came up with this list initially of 19 descriptors. Some of them you could argue are a bit synonymous, but you know, again, people use different words at different times, and so we thought we would capture more even if we had some that were sort of synonymous. And we gave this then to normal subjects whom we made short of breath in the lab. So along the top here, you can see breath hold and giving them CO2, and something called driven targeted ventilation, resistive load, elastic load, changing their functional residual capacity, their tidal volume, and exercise. All stimuli to make them short of breath. And along the left-hand side here are clusters. So you take the 19 phrases and you put them into groupings based on the way people had tended to respond to them when we first tested the questionnaire. And what you can see is that for each one of these things, if you look vertically, for each stimulus, there is a unique set of descriptors associated with it. If you look across, I mean, some of the descriptors are used in more than one stimulus, but each stimulus, in fact, has a somewhat unique list of phrases. So in theory, you could take this and maybe figure out what a patient had, you know, if you knew what they were saying. So these were the three features: multiplicity, more than one stimulus; uniqueness, in that vertical row, each one had its own grouping; and sharing, meaning if I looked horizontally, the phrases were used in different stimuli. And again, this is kind of the sense of the clusters that we were ultimately started to evolve, the things that might have been, that tended to get pushed, rated together, so we thought they represented a similar sensation in the end. What was interesting is other papers started to get published looking at this in other parts of the world and found similar things. So this was not unique to the US or to English as a language. People were finding this in different places. And Dr. Binks can attest to the United Kingdom is a very different culture from the US, is that right? But they talk about breathlessness, actually. They don't talk about dyspnea. So different words, but it's, or they don't talk about shortness of breath. They use the term breathlessness. But again, the similar kinds of things evolved there as well. So what were the insights? How did the quality of sensation relate to the underlying physiology? That was the next question that we wanted to bring up. This was association, but now how do we dig deeper? And this was our hypothesis that these different qualities probably did represent different physiology. And this would allow us ultimately, when a patient says, I can't walk more than X, and you tell me how you feel at that point, maybe I can then determine why you're not able to walk farther. Because a lot of our patients have multiple diseases. They have heart disease and lung disease and problems with their legs and, you know, joint symptoms and so forth, and they're obese, and they're, you know, so any one of those could be causing their shortness of breath. Is there a way for us to sort that out? So the next thing was to do the same thing. We did the questionnaire, except this time instead of doing this with induced dyspnea, we actually gave it to patients. And this I did with a colleague at Dartmouth, and who was also a pulmonologist. And we looked at patients who came into our clinic. And again, you can see the diseases: COPD, asthma, interstitial lung disease, congestive heart failure, cystic fibrosis, people who are deconditioned, out of shape, couch potato, whatever other euphemism you want, and neuromuscular disease. And if you look at this kind of grossly, you see the same pattern, if you will, that we saw with the laboratory study. That if you look vertically, for each disease, there's a unique set of these phrases that's used. And if you look horizontally, there's certainly some phrases used more than once, and some many times, like work and effort, came up with almost every one of these conditions. So we started to then associate and think about what was wrong in these diseases and what was the physiology that kind of went with it. So air hunger, this sort of sense of I have a tremendous need to breathe, it seemed to be always associated with some stimulus of the central controller, an increased drive to breathe. The effort or work of breathing, which was pretty prevalent across all of those diseases, was probably associated with some mechanical load. So I have resistance, or I have hyperinflation, or I have muscle weakness, not much a load, but I have to do more work to get the muscles to do their thing. Airway resistance, all that stuff, that's all mechanical load. It makes sense I have to do more work, and I would feel that. Bronchoconstriction had a relatively unique one, which was chest tightness. And I could distinguish that from the work and effort, say, of an emphysema patient. And then cardiovascular deconditioning seemed to be associated with huffing and puffing. So in other words, if you run up 10 flights of stairs, you might say, I'm breathing hard, I'm huffing and puffing. When I get up there, nothing wrong with your cardiovascular system other than maybe not being in a marathon level state of conditioning. So we go back to this patient, and he's got a lot of disease. He's got COPD, it's probably pretty bad. He had lung cancer, he had a resection, he's got reduced lung volumes. He's complaining about huffing and puffing. What do you think's wrong with him? Might just be out of shape because he's been sick for a long time and been pretty much sitting at home or in the hospital. And so now he gets up and now he's recuperating, and he's getting up and he's starting to walk. And, he's got all the things that happen when you're out of shape in terms of the cardiovascular fitness, which also in people, it's not all that well worked out, but we think that there are receptors in our muscles, sometimes called ergoreceptors, sometimes metaboreceptors, that may sense changes in the local milieu, so that if you get a little local acidosis, for example, it gets sensed in a way that we get uncomfortable, and that's probably a lot of what the deconditioning is due to, as best we can tell right now. And a lot of these patients get into what I call a cycle of deconditioning, that they have a disease, they get short of breath, they reduce their activity because, if you hit your head against the wall, what do? Stop hitting your head against the wall. So if walking up 2 flights of stairs makes me short of breath, I take the elevator. If walking to the store makes me short of breath, I get my daughter to go to do the shopping for me. Right? So in the end, you get less and less condition, and then you get more short of breath, and then you stop even more activity, and you get into this very vicious cycle. And now they try to do something, and when you all exercise, your ventilation goes up. Well, you don't immediately assume that that's pathologic. But they know they have these diseases, so I'm breathing heavy. It must be because of my underlying disease. And they get anxious about that and stop doing the activity. So the other part is what I just was beginning to describe, what I call a cycle of hypersensitization, that they forget what normal hyperpnea. Hyperpnea is a term for increasing ventilation appropriately for your increased oxygen consumption or CO2 production. So they forget what that feels like, and so they think any increase in ventilation is pathologic, and it makes them anxious, and they stop doing it. So instead of doing a lot of testing on this patient, we put him into rehab, and he wound up doing much better with pulmonary rehab. All right, so let's stay with this patient. He comes back 6 months later. He's been anxious about a friend who's dying from lung cancer, and he's now complaining of increased shortness of breath. And he had sort of an anxiety problem earlier today. Denies any cough, fever, or sputum, no chest pain, no edema, and he says, I can't get a deep breath. Different phrase than he had before. Can't get a deep breath. And he gets admitted, this is a true story, he gets admitted to me in the ICU. Some of the history is different, but large part true story. Admitted to me in the ICU with a COPD exacerbation. So I don't know how familiar people are with that term, but it's usually associated with a patient with emphysema or chronic bronchitis who has increase in cough and sputum, often an infectious component, and they get more short of breath. And they get treated with bronchodilators, and they get treated with antibiotics typically. Now there's some things that are a little bit off here because he didn't have a cough, he didn't have fever, he didn't have a change in the sputum. They weren't really working the problem. They were looking at what is common, something called availability bias. So it's a cognitive bias that the ease with which you can recall something makes you overestimate the probability that that thing will be present. And they admitted him. But I was a little skeptical because there were a lot of features that I would have thought to be present were not present. And he had this x-ray. Anybody want to take a shot at it? If you had any x-rays yet? Not too much? So there's a way to decide whether the lung volumes are the appropriate size or not by counting ribs. And a normal inspiration, when you do an x-ray, you tell a patient to take a deep breath. Normal inspiration might go to about the 10th rib. And this patient's down around the 12th rib. And if you look here, there's an area of kind of darkness, just black. There's ribs coming around, but not a lot of these little lines in the background. So he probably destroyed some lung tissue there and has what's called a bulla, which is an area in the lung in emphysema where the recoil forces of the lung are greatly reduced. So this looked like a really hyperinflated lung, which you can see with a COPD exacerbation. It's usually associated with people's respiratory rate going up. And they don't have time to get the air out because they have increased airway resistance. So they take their next breath before the first breath is all the way out, and they keep doing that until their lungs get really big and they're literally breathing near their total lung capacity. Now that makes you really short of breath. You say, I can't get a deep breath because I can't get a deep breath because there's a limit to how much I can expand my lung and chest wall. And so this is kind of the notion behind that, as I was just describing: increased resistance, something called flow limitation, with the increased respiratory rate causing hyperinflation, the lung is too big, reduced inspiratory capacity, he can't get a deep breath, and that's exactly what he says. And they breathe at the high end of the lung volumes where the curve for the respiratory system starts to flatten out, less compliant, more work of breathing. So here's a nice physiological hypothesis for what's going on with him. And I urge all of you, medical students, as you're learning physiology and anatomy and all these basic sciences in the first 2 years, there is a reason why. If you actually learn it and you can apply it, it will help you understand why these things happen and what the answer was. So he gets up here now, he's breathing at these high lung volumes, he can't get a deep breath, his brain is saying, take a deep breath, and so there is a dissociation between what he expects to get and what actually is happening. He wants a breath that's this big, and he only gets it this big. And that turns out to be an incredibly strong stimulus for dyspnea. When there's a discordance between what you expect, it could be pressure changes in the lung, it could be inspiratory flow, it could be the size of the breath. All of these things are what you're monitoring in a sense. Without thinking about it, your body monitors all of that. And it says, I wanted this, I expected this, it's not happening. It's like alarm bells go off in your brain. And so this is probably part of what was going on, this what we called efferent reafferent dissociation. Efferent is the outgoing messages from the brain to the muscle. Afferents are receptors that are sending information back to tell you what's happening. So these two x-rays, this was the one he was admitted with. This was one 30 minutes after he got to the ICU. Anybody want to guess what the intervention was? So you can see the lungs are much smaller now, and he was feeling much better. Any idea what the intervention was? Yeah, you would have thought it had maybe a bronchodilator, inhaled steroids, and that's what you would have thought. They were trying to do that in the emergency department with him, of course, but it wasn't working so well. That's why he got admitted to the ICU. So I said, you know, I don't think this is a COPD exacerbation. Didn't have increased cough, sputum, fever. This came on very suddenly tonight when he got anxious, worrying about his friend.
Did you have a van or support camp or something?
Yeah. So that might have been, so we thought maybe he got anxious and his breathing rate went up and they didn't have enough time to exhale, and then he got more short of breath, and then he got more anxious and he got into this vicious cycle. So those would have been very good things to think about. What I actually did was I sat down at his bedside and I taught him something called pursed lips breathing, which is you breathe in through your nose, you breathe out like that. And there's a lot of debate about why pursed lips breathing works, but I think one of the ways that it works is that it slows your breathing rate and allows you time to exhale, allows you time to get away from the dynamic hyperinflation. So again, this was a treatment that I did based on my understanding of the physiology and based on my understanding of what he was complaining about and where his shortness of breath physiologically was likely coming from. All right, so this was a study, was one of the papers that was circulated to the medical students. And I talked about this notion that effort and work of breathing was becoming the explanation for most dyspnea. And I had some questions about that. It didn't seem quite right, and there was sort of this difference, perhaps based on what the stimulus was for the CO2. It just had a hypothesis that maybe this wasn't correct. And the issue to me was, where is the sensation coming from? Because, you know, we'd all observed that we increase our ventilation a lot when we exercise, or voluntarily I could ask you to start breathing a lot, and you wouldn't feel all that short of breath. But when you were getting a stimulus that came from chemoreceptors, or that came sort of from the brainstem, if you will, rather than from volitional control, that it seemed to be different. So how would you test that, right? We'd have to give some stimulant, have to have them breathe the same amount, have to match the effort. I'd have to control for the effort, but change how that was being generated to see whether that mattered. So that's what we did. So we had people target their breathing, and I won't go through all the details now about how, but a way that we could measure with their breathing, show them a target, and say, okay, you're going to breathe at, say, 30 liters a minute. And then that's volitional, and you can rate how much work and effort you're doing. And we said, you know, we're going to do this, and we're going to change your carbon dioxide levels. In fact, I'm not sure we even told them that exactly, but we did change their carbon dioxide levels. We told them we were going to change various aspects of what they were doing in their breathing. And we want them to rate their effort to breathe and how uncomfortable, how breathless they were, what their breathing discomfort was like. So condition A, we gave them enough CO2 to keep their PCO2 normal at 40, because they were obviously breathing 30 liters a minute. We all breathe 5 liters a minute. If I didn't give them CO2, they'd all get hypocapnic and have problems and symptoms from that. And then the second one is we gave them PCO2 of 50, which would stimulate their breathing, but it wouldn't stimulate them as high as where they were targeted. But some of the breathing would have to be volitional, and some of it could be reflex, kind of coming from the stimulus of the CO2 itself. And they rated their breathlessness and their effort. So what was interesting is, so I'll start with the effort. No surprise, perhaps, keeping the PCO2 of 40 and then targeting them, their effort went up. I mean, that makes a lot of sense, right? As they went through that. But with the CO2, their sense of effort went down. Because effort, we think, comes from a message that goes from the motor cortex to the sensory cortex at the same time that the motor cortex is sending the message to the brain, to the muscles. So this is called a corollary discharge, and it's basically a way that you can sense how much you're trying. So they didn't have to try as much when their PCO2 was 50. And so the sense of effort was going down. On the other hand, when we look at their breathlessness, you know, 40 to 40 was, I'm not sure what was going on with that subject, but generally speaking, the breathlessness didn't change. We weren't changing anything to them. They were doing what they were doing. And then in the patients who were getting elevated CO2, the majority of them clearly had increased breathing discomfort. Breathing at the same level, the same work and effort. So again, work and effort, not the full explanation for why people get breathless. Qualities of dyspnea in patients now. So I actually showed this one before, but again, just looking at COPD and asthma, this is going to set up the next experiment. So here are two obstructive lung diseases. Both have increased airway resistance. They both complain about work and effort, and that makes sense because they got to work hard against the increased resistance. And if they're hyperinflated, they have what are called elastic forces. But there's this chest tightness thing that's here for asthma and not for COPD. So this raises a few questions. How do these things relate? What does this mean for us? So there was a time, certainly during early parts of my career, when a patient would come in with asthma to an emergency department. They would give them a couple of treatments with a bronchodilator. The patient would say, I feel pretty good, and they'd get discharged. And they'd come back 6 hours later in like really big trouble. And they were sent home with a bronchodilator, but they came back in a lot of trouble. And often then got admitted to the hospital. So we started using peak flow meters in the emergency department. And the patient would say, I feel a lot better. And they measure the peak flow, and it's not much better. And we wouldn't send them home now. Well, I don't get it. What's the problem here? Why are they saying they feel better, even though their airway resistance hasn't really changed as much as we would have thought? So, well, they're saying better. They're saying it's a symptom, right? So they got two symptoms, tightness and effort, but they weren't being asked that in the emergency department. So we did a study where we went and we asked them. And we watched them over time as they were getting their bronchodilators. So when they came in, they were complaining about, so this is kind of a funny scale, it's the FEV1% predicted, so this is when they're pretty normal and this is when they're bad. So when they came in, they were complaining about both, effort to breathe and chest tightness. And as they got treated with a bronchodilator, I'm sorry, I got the wrong way. They came in with a lot of tightness. I had it the right way the first time. A lot of tightness here. As they got treated, the tightness went down, but the sense of effort as a proportion of responses, that's what this measures here, proportion of responses. They complained mostly about, or more evenly about effort than about chest tightness. So in other words, the chest tightness was getting better, and the effort wasn't. So how do I understand that? So our hypothesis was the chest tightness was coming from bronchoconstriction. And the bronchodilator helps fix that. But if somebody's been in an asthma attack for a while, asthma is an inflammatory disease, and they got a lot of inflammation in their airways. Bronchodilator didn't do anything for that. So I haven't really changed the resistance all that much. So their effort of breathing is still there. But their tightness went away, or it got better at least, because I was giving them a bronchodilator. So again, two different sensations actually representing two different physiological or pathophysiological mechanisms in this patient. So this led to another question, clinical observation. Again, this is, we talked again about this at lunch with some of you, the interplay between my clinical work and my research questions and back and forth, and how that helped me be a better clinician at the same time, so fully integrated. So we get a patient with COPD, emphysema, and they're in respiratory failure. And they're working hard to breathe, they look uncomfortable, it's really bad. We put an endotracheal tube in, put them on a mechanical ventilator. Man, they're happy as could be. They're totally fine now. I can go have dinner from the ICU if I need to and leave the unit, they're gonna be fine. I take a patient with asthma attack, really bad, they need to be put on a mechanical ventilator. Increased work and effort of breathing, right? Same thing, they should be perfectly happy once I take away the work of breathing, because I'm doing the work with the ventilator. Intubate and put them on the ventilator, it's miserable. It's so hard to ventilate them, they're unhappy, they are still short of breath. And I'm like, this doesn't make sense, right? What is the difference here? Again, is it more than one sensation that we're dealing with? So you can see here the first author on this study, Dr. Binks, was a prime driver of this study with us. So we took 12 mild asthmatics, meaning that baseline their lung function was fine. And we gave them methacholine, which is an inhaled drug that we use to provoke bronchoconstriction. And we had taught them to relax and let us ventilate them with a mechanical ventilator. We didn't put an endotracheal tube down, but we had them breathe with a mouthpiece. And so they could really, it sounds like it should be easy to just let the machine breathe for you. It turns out not so easy. You actually have to train the subjects a bit to really relax and let the machine do the breathing for them. So they had gone through all that. And so the issue here was what would happen if we gave them methacholine, bronchoconstricted them, made them short of breath, and then put them on a ventilator. And the spontaneous breathing here is here, and mechanical ventilation is here. This was a chest tightness rating, and you can see there's kind of all over the place, but on average, it didn't really change significantly. So putting somebody on a ventilator did not change their chest tightness, what we had suspected in the clinical realm. But if I looked at their work and effort of breathing, that went down significantly. And that's what I would have predicted, because I'm now doing much of the work. So why is my patient unhappy with status asthmaticus in respiratory failure with mechanical ventilation? Because we probably haven't done anything to deal with their tightness, their chest tightness. And the COPD patient doesn't have a lot of bronchoconstriction, doesn't get chest tightness. That's not an issue. I take away the work and effort for that patient, and they feel pretty good. So we're going to switch over here now to emotional disorders. So There are data up here that you can see about the high prevalence of some of these emotional disorders with these underlying lung diseases. And we know that anxiety tends to cause an increased respiratory rate and ventilation. And this can then feed into some of the problems that they're having as well with their disease. So what are the links between these two? I'm going to skip this, actually. We couldn't have talked about that. So there's a study. This was done by a group out in California looking at pulmonary rehab programs. And there's a big drop, as you can see here, in dyspnea-related anxiety with the pulmonary rehab program. What this is a ratio of anxiety to shortness of breath. So anxiety really high, then the anxiety comes down, and then they're left with kind of the residual shortness of breath. So a lot of what we do in a pulmonary rehab program is to help people get comfortable with their shortness of breath, that it's okay, that it's safe, that they can work through it. A big part of what we do, that sort of desensitizing them a bit to the sensation. So this was another interesting thing, kind of linking the anxiety and the dyspnea and showing us how that interplay worked. So then our group then developed, and we had, again, a very multidisciplinary group. I mentioned Andrew was part of our group for a while, Bob Banzet, who's also a PhD physiologist. Bob Lansing, who was the first author on this paper, is a psychologist. So we had a very multidisciplinary group, which was wonderful in terms of the different perspectives and expertise that people could bring to the group. And we came up with this sort of multidimensional way of thinking about dyspnea, that you get some afferent input from receptors, say lung receptors, chemoreceptors being stimulated by the disease, and that gives us some sensory quality about I'm short of breath, I have breathing discomfort. And there's an intensity to that, we call SI, sensory intensity, and there's a quality, what we've been talking about for the phrases people use, so that was, we called SQ. And then we said, that's just a sensation. What about how unpleasant is it? Because I can have a sensation, and it's not that unpleasant, like running, and I get some shortness of breath, but you might not call that a particularly unpleasant sensation. But if you're any asthmatics in the room, it's 5 to 10% of the population, so you might get an asthma attack. It feels real different, I'm sure, than from your exercise does, and you may find it much more unpleasant than exercise ventilation does. So we call that the A1 or affective dimension. And you may have some behavior that is a consequence of that, like getting yourself out of the situation that's causing you to have this problem. And it also may evoke other responses, like I'm anxious, afraid, those kinds of things. And if those second level of affective response occurs, that may give you long-term changes like the ones I was talking about. I don't walk to the store anymore. I don't climb stairs. I do other things to change my lifestyle. So this is kind of a schema that shows how a particular stimulus can lead to emotional, behavioral factors, ultimately changing your lifestyle as well, and putting that together. So we started measuring these things independently. At least we made efforts to do this and created an instrument that would allow us to try to measure each of these separately. Because if you just ask somebody, are you short of breath? The question is, how much of all these things come to play in that synthesized response that you give? That if we could separate it out, maybe we'd have a better handle on some of the things that are going on. And if somebody had a really strong emotional response, maybe we have to treat the emotional response as a way of getting the dyspnea rating down, the global rating down, because I can't treat the disease, but I can deal with the emotional aspects of it. So that was kind of the rationale behind going down this route. And then there were issues, like every research study you do, you start getting a problem. When somebody says they have effort to breathe, does that mean the muscle effort? Does that mean I'm really concentrating? Because we would talk to patients and they would tell us stuff like this. And when I go up the stairs, boy, I just concentrate and focus on my breathing because I've got to do it in a certain way, to make sure I can get up the flight of stairs. And they may say that's work. I'm like, doing this intellectual work. Well, that's not what we're necessarily talking about, right? So you have to explain to patients, what is it that we're after? What is it that we want you to actually measure? And then we had arguments, debates about how to rate the intensity of each of these sensations. So, like looking at that list of sensations or even the categories. And the question was, which one is the most important sensation for them? Was it chest tightness, is it effort, whatever? And so part of the group said you should have them rate each sensation individually, like on a 0 to 10 scale. And we tried that for a while, and it was like they were just given the same rating to everything, or almost. It wasn't. So I had been doing it earlier on with what we call forced choice. You show them the phrases, and you say, you got to tell me which is the one that's the most descriptive of what you're feeling. I don't care if the two of them are close. You got to tell me what's the most characteristic of your breathing. So that's called forced choice, and it's an established model in psychology research. And I think in the end, it turned out that was a more effective way to try to discern what was the most prominent sensation they had. We also tried to use this notion of unpleasantness versus intensity. I mean, these are not easy concepts to often explain to somebody. So we tried to use this music loudness analogy. You know, that the loudness of you're playing something on your iPhone or whatever, you know, it is what it is. You may be a really song you love, but it just might be really loud or soft. It's not unpleasant to you in a way. But if it's a song you hate, you might find it unpleasant, even though it's not loud. You know, so we were trying to dissociate those two terms in a way that people could deal with it. So, yeah, so those were kind of some of the struggles we went through with this. So then we did these stimuli to provoke dyspnea in the lab. Again, hyperpnea means just increased breathing with a resistance in this case, keeping their CO2 normal. Secondly, with a limit on their tidal volume. So if I stimulate you with CO2 and I limit your tidal volume, you're not going to like it. Imagine again running up 10 flights of stairs. I can say, you can breathe as fast as you want, but just take tiny breaths. You will not be happy, even though your oxygen and CO2 level might be fine. And the third one was a severe limit of your tidal volume. And so this was the sensory component. The sensory component is SI, and the affective component is A1. So you look at stimulus 1, 2, and 3. The sensory component was pretty similar among all of those, but look at how different the affective, the unpleasantness part was. That breathing CO2 with a severe tidal volume restriction was way more unpleasant than just breathing through a resistor. So again, dissociating the emotional reaction, if you will, from the intensity of it. And here are some of the sort of secondary affective things: depressed, anxious, frustrated, angry, or fearful. And again, the one that really pops out is the stimulus 3 with hypercapnia and really reduced tidal volume. Provoked all of these emotional responses. Again, getting to the next levels of what symptoms do to people and how to think about treating symptoms in a holistic way. We then tried to decide about measuring people out of the lab, but at home. So we had COPD patients. We gave them a log to keep about the intensity of their dyspnea, what they were doing, how they reacted to it, all that stuff. And these were like bad COPD patients. We expected they'd have all kinds of dyspnea at home. They bring back the logs. It never goes above 2. Like, what do you mean? It didn't go above 2 for the last 2 weeks? How could that be? Well, I never pushed myself to make it go above 2. If it gets to 2, I stop. I don't want it to be worse than 2. So it was a good inkling to, again, the behavioral response of the patients and how when this affects lifestyle, because they literally avoid anything that will provoke them to have bad dyspnea. This was, I think, one of the more elegant studies we did. I've mentioned that I'd done some work on spinal cord patients as well, but we took a patient with a high-level spinal cord lesion, so they were ventilator dependent, so above C3, which is where innervation of the diaphragm starts. And we gave them a little bit of CO2, and we changed the tidal volume while we did that. So then they're not doing any work of breathing. This is all about us controlling the ventilator, and we kept the CO2 at the same level. And you can see that what we have here is tidal volume on this axis, And then we just were changing the tidal volume and looking at dyspnea ratings down here, that the dyspnea ratings went up every time the tidal volume went down. So this is a very, very strong stimulus. Again, that discordance between what I'm expecting based on my drive to breathe and what's actually resulting makes people very unhappy. So this is kind of a synthetic way of kind of putting all this together and it gets us into where we started using furosemide. So if we have sensations from the lungs going up to the brain, which can lead to a sensation of air hunger, then I'm going to have output from the respiratory centers to the muscles, and then I'm going to ventilate my lungs and get some tidal volume here. So kind of these feedback loops that we have from afferent things and then the efferent output that goes from the brain, both to giving us a sensation over here as well as stimulating the respiratory muscles. And the notion was that if we could do something that would inhibit the input from the lungs or change the input from the lungs in terms of tidal volume, in other words, make the body think it was getting a bigger breath than we thought it was, that we could alleviate the dyspnea. In other words, if we could make the patient feel like they were up here on tidal volume, even when they were down here, they would feel better. And some animal research had suggested that furosemide would stimulate stretch receptors in the lung that would make you potentially think that you're getting a bigger breath than you were. So that was the hypothesis behind it. And the first study that we did, it seemed to indicate that this worked. That is to say, when we made people short of breath and limited their tidal volume, we had this kind of dyspnea rating or air hunger rating. With furosemide, the dyspnea went down. And the control was just giving them inhaled saline. And again, you see up and down, but no change on average here. So this looked like it was a very promising study that maybe we could do something like this for people in whom we couldn't treat their disease anymore, but we could make them feel like they were getting a bigger breath and that they would feel better. Subsequent studies have not panned out quite as well. And it looks like maybe there's a subset of people who respond to this. Maybe there's something different about either how they're processing information or about how they're reacting to the furosemide at the level of the lungs. Because we do get people with some very big responses, kind of like this one here, even though that was with saline, but I guess this one over here. Some very big ones, and the question is whether there's something different about those individuals reacting to the drug, or is this just become more random noise? So I'll leave you with this last thought about curiosity, which I was asked to give a talk over in Europe last fall about what's, picking the right medical student. What should we look for when we're picking the right medical student? And there's a lot of debate probably about that in the United States these days. And I boiled it down to curiosity and a motivation to learn. I think they're linked. My view is if I have somebody who's curious and wants to learn, then they're going to learn and they're going to be great doctors and they're going to be curious about their patients as well as about their diseases, and they're going to be fine. People wonder whether you can teach curiosity. I'm not sure about that. I suspect you can't really teach it, but my argument is we're all born with curiosity. That if you ever look at a toddler, beginning to crawl and move around, all they do is explore the world. They pull on things, pick them up, throw them, taste them, that's all they're doing is exploring and being curious. Too much of our education system historically has probably beat the curiosity out of our students. And certainly we are, I know at our med school, we've just changed our curriculum in a way that we think will support curiosity. But I think we all are responsible to some degree for our own curiosity, not just what others do to us. But I would argue for you all to retain that, both for research purposes, but also obviously for those of you in med school, to how you approach your patients. When people talk about humanism, my view is that if you're curious, you're going to be a humanist, because you're going to be curious about who that patient is lying in front of you, and that's what kind of makes you a humanist in many ways. So curiosity, I think, works in a general global sense for being a doctor. So just quickly to summarize, I think the big take-home points, there are qualitative descriptors of dyspnea that do provide us with insight into physiology and diagnosis. I think the future of therapeutics for dyspnea is going to be to find more things that might work on some of these elements that we've been talking about, even when I can't fix the disease, that efferent, reafferent dissociation. And in a broad sense, please continue to be curious and nurture your sense of wonderment about what you're seeing in your patients. So thank you for your attention. Thank you for the invitation to come and spend some time with you. Do you have a few minutes for questions? Yeah? Okay. Yes.
So one question I kind of had throughout was when patients reported different symptoms, like tightness, work of effort, how much of the research looked at how that changes over time, and how when one sensation is diminished, another one becomes strengthened, and how you could use combination therapy or something like that to kind of balance that as that is mapped?
Yeah, so great question. For people with different phrases, have we looked at how they change with time or different therapeutics for different ones? The only one we really have done is the asthma one, because it's an easy disease to bring on in the lab and also just getting patients clinically. With this last thing, this multi-dimensional profile, this instrument we developed with the other stuff, we started thinking about, this patient with high anxiety, fear, or whatever, we might be able to do cognitive behavioral therapy or maybe even anxiolytics or something like that, but haven't really been able to do that systematically yet. But it's a good question, yeah. Other questions? Yes?
I have a quick question about whether or not this was used as a diagnostic tool at all. I don't know much about it, but are different sensations of shortness of breath used to kind of differentiate which disease process is going on?
Yeah, I certainly do. I don't think it's taught enough yet in medical school, so I don't think it's really caught on as much as it should. I think it's starting to get out there. But I mean, I'm not saying I never get an x-ray or do a spirometry or something, some other test. But like that patient, comes in talking about huffing and puffing, I will do maybe some limited stuff to make sure there hasn't been a change in gas exchange or lung function, and then say, you're probably out of shape, we need to get you in rehab, or you need to start doing some exercise at home. They have chest tightness. We did one retrospective study. I was curious, we were doing methacholine challenges clinically. A patient comes in with, often a young patient, I'm short of breath with activity, they go see a doctor, all the tests are normal, but they say when I do this or I'm exposed to this, and it looks like maybe it's asthma sometime, and we do this methacholine challenge to bring it on. So we went back and we looked at the people, what they said about their sensations before the methacholine challenge, and looked at the ones that were positive versus negative. All the ones that were positive, they talked about chest tightness, and the ones that were negative, they never talked about chest tightness. So I do fewer methacholine challenges now, and more likely if they talk about chest tightness to go ahead and treat it if the rest of the history is at least suggestive of that. So you can use some of this, I think. And the dynamic hyperinflation, I can't get a deep breath, we'll use that a lot for explaining what goes on. I'll give you an example that haven't really tried in a systematic way, but I've written up a case report on it. A patient with bad COPD who would had cardiac disease as well, and he'd get a little bit of chest pain, and it would really make him anxious. And he would get tachypnic, and he would get dynamic hyperinflation, and he would get really short of breath, and he got intubated. And we'd extubate him, and he would do this again. And people would want to intubate him. And I said, no, let's give him some morphine. Let's calm him down while we're then trying to treat, the rest of his chest pain and so forth. But you calm him down enough that his respiratory rate would slow, the dynamic hyperinflation would get fixed, he didn't look so bad, and we avoided intubating the patient. So I'm more prone to do that now clinically. I've had several anecdotal experiences now with it, so you could argue I should do the study, but it's not an easy study to sort of do in the clinical realm right now. But it's another example of how you're using this sense of, I can't get a deep breath, linking that up with what I think is dynamic hyperinflation, and then trying to prevent that from happening as a treatment rather than waiting for him to get into trouble. All right, good. Thank you very much.